And we can have an opportunity for case discussion. We have a lot of people from different disciplines here, and it's going to be a great time. Next slide. Okay, yeah, and as we say over here, right, we'd like you to share any cases you have. Our team is willing to teach and share our collective wisdom with you, and we love challenging cases. Next slide. So, we commit to maintain a confidential and safe environment for learning, mutual learning, encouragement, no negativity, no shame, no blame. And just a reminder that these case consultations do not constitute or otherwise establish provider-patient relationships between any of the echo specialists and patients whose cases are being presented, but instead it's really just a forum for learning. So yeah, all presentations, if you have any, should be de-identified and HIPAA compliant. And also to note that these echo sessions are recorded and can be accessed on our website. So your participation constitutes your consent to recording. Next slide. So this is just a little bit of a Zoom logistics. If you haven't used Zoom, right? There's a chat tool at the bottom. So click on that chat tool and enter your name and your organization. That's our way of taking attendance, and then just press enter. There's also a mute button at the bottom left. So just make sure that's muted when you're not speaking. And of course, we'd love you to unmute when you'd like to speak. Next slide. Okay, these are the topics coming up today. We have August 11th, it's hearing loss. And we have Dr. Hall, Samantha Robler, and Lisa Taniguchi here. And I will introduce them shortly. I just want to note that next month, September 8th, the echo session is going to be canceled, and instead we want to encourage you to attend the AHEC conference on September 11th. It's that same week, it's on a Saturday. And Michaela just put in the chat box the link to register for the AHEC conference. There is a geriatrics track, and it's going to be fantastic. So it's a good chance to meet a lot of other providers, I guess, online. Okay, next slide. Okay, also, we will have CMEs available. So in order to get CMEs, you have to have registered for this echo session, and also to have completed an evaluation, which will be which is on the same website in which you registered. However, it'll also be a link in the chat box at the end of the session. So make sure that when you put it in, you also put in what type of CME you're looking for. Nurses for CE, or social work CE, or MD CMEs. Next slide. Okay, so just want to introduce our usual hub team here. That's me here with the Department of Geriatric Medicine. I'm the course director for the Echo Geriatrics Clinic. We have Mary Gotham, and you can wave. Hello, hi Mary. Hi. She's retired from the Department of Health, but has decades of experience in public health nursing and knows the local resources super well. The other two cannot join us, but we actually have Noreen Wong here. She used to be a part of our hub team, and so I'm sure she can chime in and pipe in if needed. Next slide. Okay, so I'd like to introduce today's speakers. So first up, we have Dr. James Hall. He's a PhD and internationally recognized audiologist with 40 years of clinical teaching, research, and administrative experience. He received a bachelor's degree in biology from the American International University and a master's degree in speech pathology from Northwestern. He has a PhD from Baylor College of Medicine. And during his career, he's had clinical and academic audiology positions in major medical centers and leadership roles in the American Academy of Audiology. He has authored over 200 peer-reviewed publications, articles, and book chapters, including 10 textbooks. He holds academic appointments as professor at Salus University and UH as well. and even extraordinary professor at the University of Pretoria, South Africa. And he is joining us 6 hours time zone difference. Talk about dedication. He's joining us from the East Coast. So thank you so much. Next slide. We also have two other audiologists with us. We have Samantha Robler. Wave hello. Okay, she is a population health provider for Norton Sound Health Corporation and adjunct assistant professor at UH as well. She's a graduate of Gallaudet University of Washington in Washington, D.C., and she has clinical and research interests in innovating and improving tools that address accessibility to hearing healthcare, including development and application to telemedicine technology in the clinic and addressing hearing health and public policy in hearing healthcare delivery system. Wow. And last but not least, we have Lisa Taniguchi, who is currently an assistant professor here at the Communication Sciences and Disorders Department at UH Jabsom. She's a clinical audiologist at the UHP, our clinical providers here in the Hawaii Speech and Hearing Clinic. And she's a proud alumni of the program. And she is wanting to expand audiology services here in Hawaii. And so she's got outpatient clinic and private practice focusing on adult and geriatric care for the past 9 years. And specialties include audiology, vestibular diagnosis, amplification, and oral rehabilitation. She has a passion for community outreach and providing hearing screening and spreading awareness about hearing in healthcare. All of our speakers have disclosed that they do not have any relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. And I'm just looking over here, and we have a lot more people have signed in, so I'm really excited about that. That's great. So make sure that you guys have all chatted in the chat box your names and your affiliations, and that way we can have good attendance records. So please do that. Thank you very much. Over to Dr. James Hall to do the presentation. Thank you.
Well, thank you very much, Dr. Wen. I'm going to just share my screen and make it big so everyone can see. I hope that that's visible to everybody. Well, it's a pleasure to be able to give this lecture. As Dr. Wen mentioned, I'm on the East Coast. I'm in the state of Maine, where it's quite cool right now, and 6 o'clock at night, or a little after 6. So my day is just ending, but I know you're probably skipping lunch for this lecture, and I hope that I give you plenty to chew on and digest. I'm going to be giving the lecture, but then Lisa and Samantha will be available if there are questions that come up. I'm going to give an update on the assessment and management from an audiology point of view of age-related hearing loss. And I'm actually going to update you on some very exciting new information. It turns out that age-related hearing loss is not really related directly to age. So there's nothing about age that causes the hearing loss. And in fact, many of the contributors to hearing loss and as a person gets older can be addressed by either you, a physician, or the patient, the person that's aging, or both. And so the bottom line is that some so-called age-related hearing loss can be mitigated and perhaps even prevented, which is very, very exciting. The learning objectives are what we put into the CEU application. I'm going to define presbycusis. That's kind of an old term, but literally an old term about hearing loss and aging. But you'll know what that means. You'll run into that term in your interaction with audiologists. And then I'm going to identify 3 factors that contribute to age-related hearing loss. You'll certainly be able to identify those at the end. You'll be able to recognize the typical pattern of hearing loss, particularly with the audiogram, the pure tone audiogram, when we get done with this lecture. And then I'm going to emphasize throughout the link between cognitive function and cognitive impairment and hearing and hearing loss. I hope that you integrate into your clinical practice some of the information that you're learning today. At the very least, I hope you identify adult patients who are at risk for hearing loss and send them to an audiologist like Lisa. Um, I hope that you will routinely refer at-risk patients for hearing assessment. The hearing assessment is quite easy, as you'll soon find out. It's non-invasive, very quick, and so there's really no reason not to refer patients for hearing assessment if you think they're at risk for hearing loss. You definitely will want to include some questions about hearing your patient history, and I'll give you some suggestions a little later on. And then, of course, if patients do have a hearing loss and they're kind of reluctant to do anything about it, you should encourage them to seek help, because hearing loss doesn't just affect hearing, it affects quality of life, it affects the ability to communicate, to live independently, there is even a connection between economic welfare and hearing. So without any further ado, we'll move on. These are the topics I'll be covering, and I'm going to move through this very quickly so that we will have time for some questions at the end. I'll first define prevalence of hearing loss in aging adults. I'll give you a quick overview of how we assess hearing loss in adults, the techniques we use, and that'll lead to a brief review of the patterns of hearing loss that you will find in people during the aging process. One of the big exciting discoveries, and this has been reported in individual studies in the literature and also systematic reviews and all kinds of combined studies. The connection between comorbid conditions and hearing is very clear. It's unequivocal. And many studies have shown this. So we're going to review the comorbid conditions that you need to be thinking about that put a person at risk for hearing loss. And in some cases, it's a two-way street. The hearing loss can actually affect the comorbid condition. And I'm going to make the point and give you a few examples of how healthy living can contribute to healthy hearing, and particularly lifestyle changes. And we'll wrap up with just a very brief overview of what we can do for patients who have adults who have hearing loss that can't be medically or surgically managed. Well, the word presbycusis is derived from the Latin for aging or elder and hearing. It's a term that kind of implies that everybody's going to have a hearing loss when they get older. And so I don't really like the term. It's kind of confusing and not really accurate. Hearing loss definitely is more likely as a person gets older. And you can see the statistics here. So by the time you get up to the 60 and over population, 1/3 of persons have a hearing loss that really is disabling. Now, they may not recognize it and they may not seek help for it, but they have the hearing loss. And then when we get into older populations, it's even more likely that they will have a disabling hearing loss. So obviously, age alone is a risk factor for age-related hearing loss. Now, that really underestimates the seriousness of the problem. That is, the findings on the simple pure tone hearing test, the audiogram, that most people are familiar with. Because when you evaluate a patient using more sensitive tests and more tests that tap into more real world auditory skills, like listening to people speak and particularly trying to perceive what people are saying in background noise, or measuring specific parts of the ear like the middle ear or the cochlea, the inner ear, then the prevalence of hearing loss is much higher. In fact, it's very rare to find someone up in the 60 to 70 year range who has perfectly normal auditory functioning. Now, there's this misconception that everyone should go to see a physician before they go to see an audiologist, and that physicians must rule out serious disease and pathology that might be giving rise to a hearing loss. But that's a myth. And this wonderful study by David Sapal and colleagues at the Mayo Clinic in Jacksonville, Florida, is probably the best evidence to dispel the myth. They found that if you are looking at a Medicare population, so a group of older patients coming in with hearing complaints to a clinic, that over 90%, in fact, over 94%, do not have any disease or pathology that requires a physician. In other words, the average older patient can come straight to an audiologist, or you as a physician can send that patient straight to an audiologist. They don't need to see an otolaryngologist. There's nothing medically or surgically that can be done for them. And that's because the vast majority of adult hearing loss is due to two etiologies, either the problems associated with age, which we're going to discuss, or exposure to high intensity noise. And when you get into the real diseases and pathologies that a physician might diagnose and treat, and particularly an ear, nose, and throat physician, they're very rare in the elderly. I mean, they're almost non-existent. Now, there is plenty of information on hearing loss and aging, including information for physicians, family physicians, um, uh, physicians that specialize in aging adults, internists, etc. And I'm just showing you one of many articles. You can easily find them online. With this article, I'm going to point out two things that are in the table. The most common hearing loss that you'll find in an older adult is what we call sensory neural hearing loss. But in almost all cases, it's not neural, it's sensory. The problem is in the inner ear, the cochlea, and it may be related to any number of factors as you see here. So there may be it may be the result of drugs, prescription drugs that might be ototoxic, or disease processes, or as I've mentioned, noise, other factors. But it's rarely a disease that can be treated medically or surgically. The other common finding in older patients, and audiologists run into it all the time, is excessive cerumen, excessive earwax in the ear canal. As a person gets older, the earwax is not quite as liquidy as it was when they were younger, and it tends to accumulate, and at times it can occlude the ear canal. And we have all had experiences, we audiologists, of patients who are 75, 80 years old, and they'll swear that their hearing loss just started. And you're looking at the person's hearing test results and looking at them and saying, oh, this has really been going on, really started when you were 20 years old, not just recently. But what's happened is they have a age-related hearing loss, presbycusis, but then recently the earwax is built up to the point where it's beginning to occlude the ear canal. So they really did experience a sudden change in hearing, but it really wasn't because of aging. So one of the first things we always want to do is make sure the ear canals are clear and clean before we conduct a hearing assessment. Now, another important point I want to make from the literature, and this is rather recent, is that people are appreciating that hearing loss just doesn't affect the ability to hear. It goes far beyond that. It affects the ability to engage socially, to interact with people. Hearing loss leads to isolation, sometimes even depression. It affects the brain, and it's the if you don't use it, you'll lose it philosophy. So hearing loss in aging, chronic hearing loss, will begin to have secondary effects through neuroplasticity on brain function. So the person starts out not hearing as well, and then they're going to hear even poorer because they're not getting the auditory stimulation that they need. And that also impacts cognition. We'll talk more about that later. And of course, the ability to hear effectively, to communicate effectively, affects quality of life and other very important things, such as the ability to hold a position, hold a job, the ability to live independently, etc. So that's documented in this wonderful article by some very big names in hearing and epidemiology of hearing that I recommend to you. Pardon me. Now, there are risk factors for hearing loss, and this is where a message I really want to convey to all of you. You can help a person, particularly if they're in their 30s, 40s, 50s, 60s, help a person never develop significant age-related hearing loss by addressing these risk factors. And we're going to talk more about them in a minute when we get to the comorbid conditions. But by risk factors, I'm talking about cardiovascular disease, even hypertension, even high cholesterol can affect hearing. Dietary habits, exercise, of course, those are under the control of the patient. Smoking, horrible for hearing. We'll talk more about that. Diabetes is probably the #1 comorbid condition associated with hearing loss. Exposure to noise is something you should always ask about. And it doesn't have to be industrial noise. It can be non-occupational. It can be recreational. It can be loud music. It can be sporting events. They're all different types of non-occupational noise. Treatment with potentially ototoxic drugs, aminoglycosides are a common example. Lasix, cisplatin, all can affect hearing. There are some racial factors, but they're really of minor consequence and obviously can't really be manipulated. And then there's hereditary factors. So those should be asked about in your history. Now, so there are guidelines. This is again from the article that I just showed you, guidelines for what you should ask or how you should screen for hearing in older adults. And different organizations have different guidelines. But the main point is to ask about hearing and ask about how the person functions in the day-to-day environment, not just in the clinic when you're talking to them in perfectly quiet environment while they're sitting close to you and watching you speak, but in all settings. And you also could administer, or the patient could complete while they're waiting for you to see them, one of the validated inventories or questionnaires, which really get at whether or not a person's hearing loss is actually impacting their day-to-day function, their quality of life. There are many of these that are available. This is just one of many. And they don't take long to fill out. They're very easy to score and they're validated. Okay, so how do you evaluate hearing in anybody, but particularly in an adult? Well, it's a lot easier to evaluate hearing in an adult than it is in a very young child. For those of you who do see pediatric patients, we can evaluate hearing in a child within hours after birth. That's one of my specialties. We usually wait at least a day or two after birth, but it can be done. But in adults, it's usually quite straightforward. There only really one major challenge in the assessment of hearing loss in older adults, and that is we always have to take into account cognitive status or cognitive functioning. So let's review quickly the techniques that we use to evaluate hearing. There really are 4 techniques. So when you go to an audiologist, usually you'll be evaluated with at least 2 or 3 of these techniques, and very often all 4. Pure tone audiometry is the traditional hearing test, and it usually is done with air conduction signals that are presented through an earphone, and sometimes also with bone conduction signals that go straight through the bones of the head to the inner ear. Speech audiometry is a really important part of any audiological assessment. We don't walk around during the day listening to pure tones. We never do that, but we do listen to speech. We listen to it in quiet, but more often we have to somehow figure out what somebody's saying in a noisy environment. So both types of speech audiometry, both types of tests are important, but the speech perception and noise is really critical. Now, there are a series of different tests that we can do to measure how well the middle ear is working, the eardrum and the middle the bones, the ossicles behind it. And these tests are far more sensitive than any other measure for detecting problems in the middle ear. Now, they're not very common in older patients, but tympanometry only takes a few seconds. So it's always a good use of time to just rule out any medically treatable problem with the middle ear, such as otitis media. Now, it doesn't happen often in adults, but occasionally you'll have adults with sinusitis, congestion, people that have just flown on an airplane where they will have some eustachian tube dysfunction, and we'll pick that up quickly with tympanometry. Now, there's another measurement that we make at the same time, typically. It's a measurement of the acoustic reflex. And I won't get into all the details, but I'll simply say it is a reflex, it's objective. And so if you have a patient with cognitive problems, an older patient, and there's some difficulty with pure tone audiometry and getting valid results, or speech audiometry, acoustic reflex measurement can be used to determine whether or not someone has a hearing loss, and even whether or not there's a central nervous system component to their problem. And then the final test that's becoming a routine part of audiological assessment is otoacoustic emissions. And I'm going to just quickly describe each of these in a moment, so I won't go any further on in my description of that right now. So our goal is to evaluate the entire auditory system, not just the ear. We start with the middle ear, and of course we look in the ear canal. Some of our tests actually give us information about the ear canal. Then we need to evaluate the middle ear, the inner ear, or the cochlea, the auditory nerve, the 8th cranial nerve running from the auditory, from the cochlea to the auditory regions of the brain, and then of course the brain itself, the brain stem and the cerebral cortex. So we want to typically with any patient, but particularly with an adult, evaluate as much of the auditory system as we can. And some adults may actually be at great risk for problems affecting the brain, not the ear. Among those would be patients with traumatic brain injury, and certainly any kind of neurological insult, like a stroke or an aneurysm or a tumor. So pure tone audiometry, I'm sure you've all had it. Very simple test. It's been around since the 1920s. The patient sits in a sound treated room typically, although it's not necessary. There are some automated audiometers with fancy earphones and that attenuate sound that allow you to actually perform pure tone audiometry in just a quiet clinic room. It doesn't have to be a sound booth, but typically it is. And the audiologist is sitting outside the sound booth with a device called an audiometer. Inside, the patient's hearing sounds in some form or fashion, either with earphones that fit over the ear or with what we call insert earphones, little foam cushions that fit down into the ear canal. They're preferable for many reasons. And in the elderly, insert earphones are very, very useful because the ear is mostly cartilage. And as a person ages, the cartilage loses some of its stiffness. And putting the earphones over the ear can actually sometimes collapse the ear canal. And now sound's not getting to the inner ear as it should. So we have different ways of getting around that, but insert earphones, which are shown on the right of this slide, are the best option. The other big advantage of insert earphones is you can throw away the foam tip at the end of it all. They're disposable, so you can minimize risk of infection and practice universal precautions. In many cases, bone conduction is needed. In most cases, it's done. Sometimes it's not needed, but it's usually done. It doesn't take that long. And with this, we put a little vibrator, bone oscillator, behind the ear on the mastoid bone, and we compare the results of air conduction testing and bone conduction testing. They should be the same. The equipment's calibrated so that we use the same intensity for air and bone. If there's worse hearing by air conduction than there is by bone conduction, that means there's some blockage either in the ear canal or the middle ear. Now, speech audiometry, as I've already said, it's a critical part of an audiological assessment. In my opinion, it's the most important part because people come in to you and say, I'm having trouble hearing people in a restaurant or out in a waiting room that I didn't hear my name being called. Or when I'm at work, I'm getting in trouble because I'm not understanding what my boss is telling me I need to do. So speech audiometry really gets at the problems that most people have, including people as they age. And so we always want to evaluate that as audiologists. So again, the patient's usually inside a sound booth, we're outside, and we use recorded materials. Typically, we use recorded materials that have been around since the 40s and 50s, and some are more recent. And these recorded materials consist of words and sometimes sentences. And sometimes the words or sentences are presented in a perfectly quiet setting at an intensity level that the person can hear. And we determine whether or not they're perceiving these words or sentences by their repetition of them or their response in some way. Sometimes they point to a picture, sometimes they identify the sentence they hear. But one way or the other, we're evaluating the person's ability to perceive speech. Now, we like to do this always in quiet. That's the traditional approach. But there also are more than a dozen tests of how well a person perceives speech and noise. And again, that's a very, very important test because that's the chief complaint that we hear most often from older patients. I hear you fine in this quiet room, but I really have trouble in noisy environments. Now, I mentioned tympanometry. I'll just quickly say it's an objective test. It doesn't require much time. It's very simple. It can be done in any physician's office as well as school nurses could do it, and it can be, of course, be done in an audiology clinic. The equipment, a typical piece of equipment is shown on the left. That's more of a diagnostic system where there's a probe, a soft probe that we put in the ear. Air pressures change in the ear canal very quickly from positive to negative pressure. It only takes about 3 or 4 seconds. And then we record the flexibility or the compliance of the eardrum and the middle ear as we change air pressure. And this has been around since the early 1970s. So if you have a patient who's at risk for middle ear problems, maybe they are congested, they're just getting over a cold, they've had sinusitis, they've had chronic problems with their ears. This is an excellent test to determine whether or not the middle ear is functioning normally. If it's not, then we move on to certain tests like bone conduction. If it is functioning normally, then we can move right on to speech audiometry. We don't need to spend any more time evaluating it. And then the final test I'm going to mention is the otoacoustic emissions. They were first discovered in 1978. Otoacoustic emissions are sounds produced by the ear. Now, normally we think of the ear as receiving sound and passing it on up to the brain. But when the ear is stimulated by sound, it actually produces its own energy, and it sends that energy back out into the ear canal. So otoacoustic emissions are emissions that are sound, acoustic, coming from the ear. And now we have a variety of different pieces of equipment. This is one that's right in the clinic at the Audiology clinic at the University of Hawaii, this very device. Very easy test, very quick test with any adult. It takes about a minute or two per ear, but it provides us with an incredibly sensitive measure of how well the inner ear is functioning, because these otoacoustic emissions are produced by the most delicate part of the ear, the outer hair cells. The outer hair cells are highly metabolic. You've got thousands of them, probably 12, 15,000 of them in your ear. And anything that can go wrong with the ear pretty much involves these outer hair cells. They're so delicate and they're so dependent on an adequate supply of blood and oxygen. So if you're trying to find out whether or not a person has any problem with their auditory system, with their ear, this is a great test. And this can easily be done in a primary care physician's office or a pediatrician's office. Now, an abnormal finding, the absence or finding of an abnormal amplitude for otoacoustic emissions, doesn't mean the person has a hearing loss, but it does mean there's something wrong with the ear and they need to be evaluated further. I've written a book on this, written a book on a lot of things, as you've already heard, and it's shown here. I would encourage you all to learn more about otoacoustic emissions. You'll certainly be seeing mention of it in reports on patients, but you actually could perform these measurements in the clinic yourself. And of course, there are CPT codes for screening versions of otoacoustic emissions and diagnostic. Okay, patterns of hearing loss associated with aging. Well, I mean, every patient's individual, different, and every individual is going to have somewhat different hearing results, but there are some patterns that are very consistent with the process of aging. And one of those patterns, which has been known since the 1930s and 40s, is a decrease in the hearing abilities for high frequency sounds. So hearing thresholds, the ability to hear faint sounds, decreases as we age, and the decrease is greatest for the high frequencies. And the decrease in hearing is usually greater for males than females. Now, that's historically been very true, that males show greater age-related hearing loss than females, or more hearing loss as they age. But that's changing. Many of the differences between males and females had to do with people working in different settings or functioning in different settings over the years. So many of the differences really had to do with noise exposure. And we're now realizing, of course, with people working, males and females, in similar settings, that there's really not that big a difference in the aging process for males and females once we eliminate any possible etiology for the hearing loss. Age is not an etiology. I've written an introduction to audiology book, which this figure is from, and explains all of this. And you'll find many, many references to this characteristic pattern of high-pitched hearing loss associated with aging. But that's not all. In addition to the high-frequency hearing loss, almost every person over the age of 60 has abnormal functioning of the inner ear if you use a very sensitive test like otoacoustic emissions. Whether or not they have a hearing loss on the audiogram. As I've already mentioned, occlusion of the external ear canal by cerumen is not uncommon. Of course, that's obviously treatable. Middle ear function dysfunction is very uncommon. In fact, you can honestly say when an older person has a problem with their middle ear, it's always something of concern, because the most common problems we see in children usually aren't seen in an adult. So you would want to have that person evaluated, certainly by an audiologist. And then difficulty with speech perception, particularly in noise, is a very common problem, even in people whose hearing by the audiogram or by pure tone audiometry looks pretty good. Okay, I'm going to run through comorbid conditions definitions very quickly so we don't spend too much, we don't want to go over in time, but this is a critical topic. This is a topic that didn't even exist 20 years ago, 30 years ago. Most of the research on comorbid conditions in hearing has been published in the last 10 years, the last decade, as you'll see from the articles. And many of the articles I'm going to show you are meta-analyses. So they're based on dozens and dozens of individual studies. So the information I'm presenting is rock solid. We do know that there are comorbid conditions associated with hearing loss. Now here's a little bar graph two of my colleagues, Ian Windmill and Barry Freeman, had created. They had access or have access to Medicare data for over 1 million patients. So when a person goes to see an audiologist and they're insured by Medicare, what kind of problems do they have? And the bar graph shows that they have a lot of comorbid medical problems, coexisting disorders. Some are cardiovascular, hypertension, for example, hyperlipidemia, high cholesterol, very common. Rheumatoid arthritis is right up there. Diabetes, another big factor. Almost 1/3 of all patients coming to see an audiologist have been diagnosed with diabetes. And you can see many, many others, including some that have involved cognitive functioning, like and even dementia. Now, we're going to get to that in a moment. So this is a topic that is getting more and more attention, both in the audiology literature and the medical literature. And we're beginning to realize what chronic medical conditions are associated with hearing loss. And that's so valuable for you to keep in mind, because if you can address the comorbid conditions, you can actually help the person mitigate hearing loss. And as audiologists, if we recognize this connection, we can make sure that physicians are helping a patient properly manage their comorbid conditions to improve their hearing, or at least slow down the loss of hearing. Diabetes, as I mentioned, is #1 on the list, and it's attracted the most research attention, and clearly diabetes is going up in the United States, which is directly connected to prevalence of hearing loss going up in the United States. So every patient who's either diabetic or pre-diabetic really needs to undergo an audiological assessment. There's no question this literature is very, very well established. So this is not a theory. This has been shown in many, many studies. Sometimes the comorbid conditions that affect hearing, such as diabetes, can in fact, of course, have other comorbid conditions. So a good typical combination would be some cardiovascular problem and diabetes. They go hand in hand. And of course, that increases the risk of hearing loss even greater. Rheumatoid arthritis is definitely linked to hearing loss. The mechanisms are unknown, but there's definitely a connection. So anybody with rheumatoid abnormalities, rheumatoid arthritis, any form of arthritis is at risk for hearing loss. Chronic obstructive pulmonary disease, also associated with hearing loss. And here's, again, another systematic review of meta-analyses. And this makes sense. The cochlea must receive consistent supply of blood and oxygen and nutrients. And so there's a connection there. Any patient with kidney disease, including those undergoing dialysis, is at risk for hearing loss. And this, of course, includes children as well, but we're focusing mostly on adults. So this is a logical connection, and it's well established. And then we're going to spend just a little more time on comorbid conditions, focusing on cognition. This study in 2011 was the first, 10 years ago, to really describe this link between hearing status and cognition, and hearing loss and cognitive decline. It was a little controversial when it first came out, but now the research is unequivocal. Hearing loss does contribute to cognitive decline on average. It's certainly a big risk factor. And in treatment of hearing loss or management of hearing loss, for example, with hearing aids, can be associated with improved cognitive status. And then taking that one step further, we have the connection between hearing loss as a risk factor for dementia. One of my studies back in the mid-1990s was of patients with early Alzheimer's, just barely being diagnosed. And we evaluated their auditory function and found that they had more hearing loss, but most importantly, they had horrible problems processing speech in noisy settings. They had what we call central auditory dysfunction. So any patient that you have where there's any concern about cognitive functioning should undergo a complete hearing assessment to include speech perception in noise. This, again, another systematic review and meta-analyses. This is one of the most exciting findings really in the last 5 to 10 years, that with auditory tests, for example, assessing a person's ability to perceive speech and noise, we can detect cognitive decline before anybody else knows about it. It's one, speech perception noise difficulties are one of the very first indicators of cognitive decline. So audiologists can work with a wide range of physicians to help identify these connections and then to manage these patients effectively. And then finally, I'll point out that obviously many patients who are older who have hearing loss also have vision problems, age-related vision problems, glaucoma, for example, macular degeneration. And there's a connection between these. So if you have a patient with vision loss, think about hearing. And if we have a patient in our audiology clinic with hearing problems, we should think about vision. And the combination of these dual sensory deficits, hearing loss and vision deficits with aging, can not only affect the person's ability to function independently, can lead to problems with mental health. And this is a very strong connection. In fact, the likelihood of depression in older adults is greatly increased when they have vision loss and hearing loss. I've recently written an article this April entitled Promoting Healthy Hearing Over the Lifespan. I'd be happy to send you a copy. And it reviews all of what I've just talked about, aging process and how it affects hearing and the comorbidities. I've got a few other little articles on the same topic if you are interested. All right, very quickly, I'm watching the clock here. I've already made the point that some of the factors, the risk factors for hearing loss and aging can be controlled. You know, they can be manipulated. They can be, the risk factors can be eliminated even. So let's talk about them. Well, first is diet. The link between diet and hearing loss is now very clear. People have analyzed data for hundreds and hundreds of thousands of people, not patients, but people, and found that those who eat a more healthy diet, more fruits, vegetables, omega-3 fatty acids, drink a lot of water, are more likely to have better hearing. And those who don't, those who eat processed foods, a lot of sugar, etc., are more likely to have hearing problems. So this connection is so clear that you can counsel your patients. You can say, I've been telling you, you need to lose some weight. You need to have a more healthy diet. And one of the reasons I think you should really do that is because it's affecting your hearing. Makes the healthy diet, it gives it more of a real world impact. You'll actually have the ability to maintain your hearing or prevent hearing loss, or at least mitigate hearing loss by eating a more healthy diet. So that connection is true. And that's not just true for hearing, but also for our hearing related problems, such as tinnitus. Tinnitus, bothersome tinnitus, is a major health problem, affects millions and millions of people. It can have a great impact on quality of life. And diet is directly linked to the likelihood of tinnitus. Smoking, I've already mentioned, we all know smoking's bad. And then people think immediately of cancer, but there are so many other reasons it's bad. And now we can put hearing loss on that list. Smoking is probably the worst lifestyle habit for hearing of all of them. It's worse than diet. And interestingly, the research on this it's just emerged within the last 5 years. It's very quite fascinating, and it's quite large. What it's shown is that if a person is a smoker, they're going to have worse hearing. And yet, if they stop smoking, believe it or not, hearing can actually improve. So this is something we should talk to every patient about. We should ask if they smoke, and if they do, we should do all we can to get them to cease smoking, not just for overall health, but also for their hearing. Okay, I'm going to wrap up by just pointing out that everyone with hearing loss can be helped, and that is certainly true for adults, even adults who are aging. One of the first things we can do, and I've emphasized this throughout the lecture, is to counsel adults about risk factors for hearing loss, help them to help themselves in improving their hearing. Management of comorbid conditions, effective management, will automatically benefit hearing. Effectively managing hearing loss will benefit cognitive function. And of course, if a person is hearing better, they're going to enjoy life better. It's not just a question of decibels and the audiogram. It's a question of quality of life, enjoying each and every day of life, being gainfully employed, enjoying social activities, going to the movies, interacting with other people, hearing their grandchildren, etc. So counseling obviously should include referral of the patient with any risk for hearing loss, or if they haven't had a hearing test and they're over the age of 60, that automatically qualifies for a referral. Now, what's the audiologist going to do if there is a hearing loss? Well, the most important management strategy in audiology is amplification. Audiologists will make sure that all sounds that the patient needs to hear, including soft speech sounds, are audible, can be heard. And if the person is hearing all the sounds they need to hear, the brain will take over after that. And the brain will begin to process these sounds, and that will result in even the perception of better hearing. If the person's struggling with hearing and listening, they haven't heard well for a while and they really need some help, there are computer-based programs which patients can easily access that will improve listening abilities. For example, the ability to hear in background noise and the ability to process speech quickly. This whole concept, everything I've been talking about, trying to prevent hearing loss over lifespan and take into account comorbid conditions and to encourage audiologists to work with primary care physicians and vice versa is now beginning to get some traction. And this is a study from Australia showing the effectiveness of coordinating hearing health care among primary care physicians, patients, and audiologists. Okay, I'm going to stop at this point and we'll take any questions, and I'm going to ask Lisa and Samantha to be ready to go on duty to help me answer any questions that might come up. Thank you very much. I'll stop sharing.
Okay, I have a question. Actually, I was wondering, so this huge public health implications.
Absolutely.
Do public health nurses do screening?
And
what is the role for that?
Sure. No, I actually, if I had more time, Dr. Wen, one of my themes, one of my bullet points is the intersection of public health and audiology. And people are beginning to appreciate that. It's a huge public health issue. And there's nothing magical about hearing testing. There are automated devices that exist that actually perform just as well as audiologists. So there's no reason why a public health nurse in a setting, particularly in maybe a more remote setting in Hawaii, for example, or some Pacific island where there are no audiologists, public health nurse certainly could perform a basic hearing assessment. They could perform the otoacoustic emissions and the tympanometry. And Samantha is an expert on teleaudiology. One way this would work is the public health nurse collects the data, shares it with an audiologist remotely, who may be thousands of miles away, and then a strategy is developed for what to do with that patient. Samantha, do you want to jump in?
Yeah, I think you said it great. We're doing it now where in the RMI where there's not audiologists there, we dial into the computers and provide the testing and have technicians there getting some preliminary data, and then I'm reviewing it. So that's one way to extend these types of services. But other ways that we've done it is by putting tympanometry and otoacoustic emission screening tools in primary care clinics, like you're suggesting. And that's things that we've done in Alaska, where I primarily work, and then trying to do that in some of the grant funded work here that I'm involved in Hawaii. And then I don't know if Lisa wants to add anything that's Hawaii specific. I know she's doing a bunch of stuff in the school as well.
We just rolled out and have a contract with DOE and got all the district OAE screening equipment just so they can screen more efficiently because they don't have an audiologist within the Department of Education. So very simple to do. I train SLPs to do them, and they're doing it, on their caseloads.
The other role of the public health nurse, Dr. Wen, would be to identify which patients should undergo the next level of assessment, because they're interacting with patients on a regular basis. And the risk factors are so clear, so easy to identify. No one would think about avoiding vision testing if they're bumping into things, or if the things are blurry, they can't drive, they can't get a license. But unfortunately, hearing is neglected. It's kind of a hidden deficit. And so the public health nurse can help to identify that and bring to the patient's attention the importance of getting a hearing assessment and whatever follows from that.
I don't know, Mary, did you want to have any comments about how much hearing loss you see in public health nursing?
Sure. I can just say that, yeah, I always assess for it, but I didn't have any fancy tools, but I just see if they're, reading my lips and, quite going like this. And I do whatever I could to encourage them to get evaluated for hearing aids. What I found really problematic was the hearing aids are really hard for them to operate, like put the batteries on and even know if they were turned on or not. And I had one cute little guy that had dementia and he lost his. We looked over, we couldn't find them. And he was went to the VA, so he was so happy they gave him a new pair. He says it was free. I don't know, but anyway,
yeah, for a veteran, they would be, they of course they pay for the hearing aids with their service, but yeah, hearing aid, I'm glad you brought that up, Mary, because hearing aid technology has changed dramatically. And before long, we'll have hearing aids. We don't have to change the batteries. There are certainly
that would really make a difference, because they're fine motor and everything. It was just such an issue. And this lady, sometimes she'd put the batteries in upside down, and then she says the hearing aid no worky, and so making them easier to use would be a wonderful thing. Yeah.
All right, we have a great question from Geri Okamoto. Audiologists recommend a wide variety of hearing aids, ranging from $10 to $12,000. Is there a source of what best is?
Yeah, I'm going to let Lisa answer that. I'll just say that in the last few years, there's been a kind of a revolution in amplification, different devices. Now there are what are called over-the-counter devices. There are wearables there. So there's a wide range of technological options for hearing aids. And, I think there are certainly, so right now, as we speak, some legislation, federal legislation is being pushed forward, and some of it is going to expand the coverage of hearing services for older people. And so I think we're going to see much more of this. But Lisa, do you have any comments about that?
I would say going up to 12,000 for a pair is a bit much.
Yeah.
But there is a lot of technology out there. There's rechargeable options out there that's available at high, mid, or low level technology. Low level technology can run the gamut, I would say about 1,000 or 1,500 for a pair. There are the over-the-counter, which is kind of like, I use the analogy of readers. They will help with some mild hearing loss, but if there's more involved with moderate and then possibly some cognitive issues or speech and noise issues, we do have to consider, better technology than the over-the-counter devices. But I would say, yeah, there's a big range, and you have to really do an assessment and see what the communication needs are of the individual. They might need accessories to go along with their hearing aids. They might not. And that, of course, more accessories, more cost. If they want an iPhone connectivity, that is what kind of drives cost of devices, is how smart we want the hearing aids to be.
I think the key for me in answering Dr. Okamoto's question would be the willingness to pursue any rehabilitation is a positive, and we want to help them pursue it. So if cost is a barrier, then that's taken into a needs assessment. And as an audiologist, we would work to get them anything that could help them. So I think, the average, Dr. Hall, you probably know the literature better. I think the average from a dated study of maybe 10 years ago was 7 years from the time of an identification of hearing loss to the willingness to even try rehabilitation for fear of stigma and other barriers, which we're trying to address in the legislature you're seeing today. But I think identifying a need and then a person being willing to do something about it is really the first couple of steps. And so I think if you have patients in front of you who are interested, we just have to get them in front of the right person to get them what they need.
That's
And
a
then-
very good point, Samantha. Just to
Yeah.
quickly add that, I mean, I wouldn't even mention hearing aids in the initial discussion.
Yeah.
We want to help people. We want to help them communicate more effectively. Hearing aids are just a tool. They won't be the only tool for sure. They may not even be the appropriate tool, and particularly the traditional type hearing aids. So there is a reluctance, but hopefully with younger generations aging who are less concerned about sticking something in their ear, that will go away. Was there a question, Wen? Somebody had?
Great. Yeah, another question, right? Can you comment on the relationship between COVID-19 and hearing loss? Is there?
Oh boy, that's a great question. Obviously, with the pandemic, there's been a lot of research. I've reviewed or read dozens of articles on COVID-19 and hearing, and not just hearing, also tinnitus, vestibular problems, etc. And there are certainly many case reports. COVID, the pattern of deficits in COVID is dramatically different from person to person. But the overall conclusion is that for some people, hearing can be affected. And we don't know what the long-term effect is going to be, obviously. It can affect the nervous system, and of course, we hear with our brain. So any impact of COVID on neurological function is going to affect hearing, but then there can be direct hearing effects. Of course, people are on ventilators for long periods of time. There are going to be problems with eustachian tube function, as we see that, of course, in young infants who are on ventilators. So the final word isn't in, but there's definitely a connection. And if you have a patient who has recovered, thankfully, from COVID, they need to have an audiological assessment without a doubt. That's a risk factor.
Great. Any last questions? We have like 2 minutes left. Otherwise, I'm also gonna just say, while people are thinking, if Michaela, if you could put in the chat box, the link to do your evaluation, then we can get your CMEs. That would be great. And also, just a reminder also that in September, we are not having our usual session here, but we encourage you to attend the AHEC conference on Saturday, September 11th, where we do have a geriatrics track. Okay, any other questions? Okay, great. Anyway, thank you so much.
Okay,
That's sparked a lot of, good thoughts and ways we can improve our practice. So thank you very much.
Lisa has information. If anyone wants to needs to send a patient to the audiology clinic, Lisa is the person to contact. And of course, the clinic number is available to everybody.
Great. Thank you so much.
Okay.
Okay.
Bye,
take care.
everybody.
Bye, everybody.